How's it going, guys? Past level question for cardiorenal step 1 internal medicine 2 CK. 64-year-old man, follow-up appointment, vitals are normal, physical exam shows crackles in both lung fields. There's JVD, peripheral edema. Current medications are lisinopril, an ACE inhibitor, beta blocker, furosemide, a loop diuretic, aspirin. Serum creatinine 1.8 should be 0.7 to 1.2. Once we've hit a creatinine of 2, we've lost 90% of our renal function, which will find most likely be seen in this patient. So this patient, we're hopping right out of the gates, has congestive heart failure, which is left heart failure plus right heart failure. So left heart backs up to the lungs, hence we have crackles, pulmonary edema, backs up to the right heart, gives us systemic findings, jugular venous distension, peripheral edema. ACE inhibitors or angiotensin II receptor blockers are usually the first line agents used for heart failure. They improve ejection fraction. If we knock out the effects of angiotensin II, decrease constriction of peripheral arterioles, decrease afterload on the left ventricle, make it easier to pump, ejection fraction goes up. They also decrease remodeling of myocardium. Beta blocker is classically the second agent used for heart failure. Furosemide does not improve mortality in heart failure. It's used for improving/mitigating symptomatology, i.e. the peripheral edema and the pulmonary edema. Aspirin, baby aspirin, can be used for ischemic heart disease. We don't have overt angina here. The patient probably has atherosclerosis nevertheless. So let's just hop through the answers. What's most likely seen in this patient? Should I say baroreceptor mediated inhibition of ADH release? Wrong fucking answer. So in fact, it's the opposite. Now, what's going to happen is if we have reduced ejection fraction, now of course heart failure, you can have preserved ejection fraction, but most patients tend to have decreased ejection fraction. So the baroreceptors at the carotid sinus are going to interpret a diminished systolic impulse as fluid reduction, okay, as though there is an attenuated fluid status. And we're going to have decreased stretch, decreased firing of the carotid sinus baroreceptors, decreased cranial nerve 9, glossopharyngeal afferent up to the solitary nucleus of the medulla, decreased vagal cranial nerve 10, efferent finding down near the nodal tissue. Heart rate goes up to compensate. So it's a nodal increase in heart rate, but it's autoregulation in the setting of heart failure. But one of the second functions of the carotid sinus baroreceptors is that if there's perceived decreased fluid status, ADH goes up to compensate. Because if we have perceived decreased fluid status, wouldn't we want to retain more free water at the medullary collecting duct to try to improve our fluid status? Now, this isn't me trying to be fancy. This is asked on one of the family medicine forms for 2CK, despite it sounding very step 1-esque. They'll give you the same fucking question here. They'll give you sodium of 130, should be 135 to 145, and they'll say, which of the following best explains the hyponatremia in this patient who has heart failure? And the answer is carotid sinus baroreceptor mediated ADH release. Wrong fucking answer. Choice B, BU-endocrine ratio greater than 20, correct answer. Consistent with prerenal azotemia on a background of heart failure. Okay, so heart failure, 9 times out of 10 for USMLE is going to cause prerenal azotemia. So if we have diminished systolic impulse, reduced ejection fraction, not only are we going to have the whole carotid sinus baroreceptor mediated release, as I just harped on, but also isn't it safe to say that we would have diminution or reduction of perfusion of vital organs, e.g. the kidney? So in conjunction with the fact that the patient's on a diuretic. So even if you weren't connecting the dots that heart failure can cause prerenal azotemia, being on a diuretic is another high yield cause of prerenal azotemia. So what's going to happen here, if you wonder why the BU-endocrine ratio is greater than 20, if there's reduced renal perfusion, and hence the kidney perceives diminished fluid status, it's going to attempt to increase reabsorption of fluid in the PCT to compensate. And the way it does that is by reabsorbing sodium and urea. So by pulling urea out of the PCT, water follows. Hence blood urea, nitrogen is high, so our ratio is high, BUN's high. Okay, and fractional excretion of sodium is under 1%, choice C, wrong fucking answer. And the reason that makes sense is because if we're pulling urea and sodium out of the urine, well, if we're pulling sodium out, so water follows sodium, well, we're going to have less sodium in the urine, hence fractional excretion of sodium under 1%. Choice C, wrong fucking answer. Choice D, serum ANP reduction, wrong fucking answer, B, increased. So in the setting of heart failure, if anything, we're going to have a backup to the right heart, as I just inculcated, and as a result, increased atrial myocardial fiber stretch, ANP release. You need to know that natriuresis, fancy word that means increased sodium urination. So it prevents the reabsorption of sodium in the urine, and also it prevents the secretion of renin by the kidney. Wrong fucking answer. Choice C, serum sodium 146, wrong fucking answer. So 135 to 145 normal range. And as I just talked about a moment ago, if anything, we could have hyponatremia and heart failure, secondary to diminished systolic impulse with subsequent increased carotid sinus baroreceptor mediated ADH release. Wrong fucking answer. You know the deal. Do you make more content? If you like my stuff, subscribe my channel. And I appreciate your time. That's it.